好的，各位专家及老师，大家晚上好，欢迎大家上线参加本次论坛。我是爱尔国际战略发展中心爱尔全球视觉的项目经理沈冲。这是本年度我们开展的第2次线上论坛，然后本次的主题呢是有关屈光性白内障手术中患者选择的相关内容。在本次课程中呢，国内外的眼科专家将会以真实案例分享的形式，为大家带来详细且思路清晰的授课及分享。So hello everyone and welcome to today's webinar, patient selection for refractive cataract surgery, elevating surgery to new heights. And thank you for taking time out and being here today. I'm Shyan from IR Global Vision Care Management Company and IR Eye Hospital Group. 在此呢，我也想先给大家做一下今天介绍一下与会的几位嘉宾。首先呢是来自马来西亚的黄俊贤医生，他是我们爱尔东南亚 ISEC 集团的 CEO， 也是眼科顾问医师。他会担任今天晚上论坛的主持人，并且加入到讨论当中，分享一些来自我们东南亚爱尔的经验。然后分别是来自3位海外的眼科医生，是来自爱尔兰的 Arthur Cummings 教授，来自意大利的 Francesco Carones 教授，还有来自英国的 Sheraz Daya 教授。然后3位专家分别会为我们带来案例分享以及精彩的讨论环节。最后呢，也想隆重介绍一下来自我们爱尔中国的几位专家及教授。首先呢是来自沈阳爱尔的赵平院长，也是我们爱尔辽宁省区的副总院长，还有来自上海爱尔清亮的陈旭院长，也是我们集团白内障学组的成员，还有来自福州爱尔眼科医院的高鹏芬院长，还有来自上海爱尔综合眼病科主任的钱竹韵博士和北京爱尔英智的徐曼主任，也是我们北京爱尔的国际医疗部主任，分别为我们的专家的讲解带来详细的这个翻译和讲解。那接下来呢，我就想把这个话筒交给黄俊贤医生，请黄医生先来给我们做一个简单的介绍。谢谢。
谢谢你，苗。Welcome everyone。大家好，我是来自吉隆坡的黄俊贤眼科医生。我是在吉隆坡的国际眼科医生中心里面做那个medical director。这个屈光白内障手术目前是在国内里是一个非常热门的话题。目前我们对白内障手术过后的追求是不只是要看得见，但是我们要看得清楚，并且可能提高患者的生活的质量。Refractive cataract surgery is currently a very hot topic among ophthalmologists in China. The objective we hope to achieve with refractive cataract surgery is not only to help patients who had cataract surgery to see, but to help them to see well with good vision, especially without the need for glasses, so they can improve the quality of life and satisfaction. 屈光性白内障手术的开展要需要很多方面医术的支持，其中非常重要的一点是我们手术医生一定要了解这个 concept， 这个白内障屈光手术的要了解，因为如果我们了解的话，我们可以不但我们自己可以做一个好的手术的结果，同时也能够向患者进行的说明。The development of refractive cataract surgery needs a multi-support in many ways, among which is very important one is a surgeon must have a thorough understanding of refractive cataract surgery, which not only can help the conceptual change of the doctors from cataract to refractive cataract surgery, but also can help the doctor to explain better to patients. 在这本节课程中，我们应该会了解这些我们演讲师跟我们带来的他们的演讲，我们应该会明白了这 new concept 就是白内障是一个屈光手术。In this webinar, we'll focus on the topic of patient selection, because patient selection is crucial to the success of the surgery. How best to choose the candidate for this type of surgery, what are the factors that we need to consider, and of course, there also a real case analysis in this. 我们希望我们可以我们的目标就是我们听了这个演讲过后，我们可以明白怎么样选择一个应该成功的手术我们选择一个好的患者。Without further ado, I would like to introduce our speakers today. We have 3 overseas speakers in addition to faculty from IR. First, we have Dr. Arthur Cummings, who is currently a consultant eye surgeon in Wellington Eye Clinic and Beacon Hospital from Ireland. 今晚我们的讲师为是 Dr. Arthur Cummings 从爱尔兰来的，还有 Dr.Francesco Carones 从意大利来的。Francesco Carones is a physician, CEO and medical director of Carones Ophthalmological Center in Milan, Italy, and he has been involved in refractive surgery since 1989. And last but not least, Dr.Sheraz Daya, who is well known to most of us here, especially in Southeast Asia. He's a British ophthalmologist and had training in Ireland, UK, and US. 我们最后一名呢，就是来自英国的 Dr.Sheraz Daya， 也是有很多经验在这个屈光手术的方面。So, Dr. Arthur Cummings, we would like you to start your presentation.
Thank you, Dr. Shyan. I just need to get the ability. I'm getting a message that I can't share the screen yet. Let me try again. No, it still says I can't share my screen. I think the host just needs to allow screen sharing for me.
Okay, Mia, can you promote Mr. Cummings to?
I think it's allowing. It's working now. Thank you. It's working now.
Yes.
Okay, fantastic. So thank you once again for that very nice introduction and for the opportunity. And thank you to Sheraz, Daya, and Francesco Carones for agreeing to participate again. You know, the first webinar we had was just about this topic in general and why it's important. Why should we think about doing it? Today is more about patient selection, and you've heard exactly how important it is. How to select the right patients and how to avoid the wrong patients. So these are my financial disclosures. As we've heard earlier, modern refractive surgery is very successful, and cataract surgery today is nothing more than refractive surgery. People are living longer, they're leading active lifestyles, they want to see well, and patients are demanding excellent visual outcomes. The days of just doing a cataract and getting a good outcome but having glasses they're sort of disappearing. So what about blended vision or monovision? Well, first of all, not everyone is a candidate for monovision, especially older people. You know, they can tend to fall and this type of thing. There's a pressure to deliver complete vision following surgery, including after cataract surgery today. And patient expectations are demanding, and that includes the ability to read after IOL surgery. So we need excellent results. We need it for patient satisfaction. We need it to improve patient lives, their performance and prospects in life. We need to grow our own practices. We need to grow the market. And at the end of the day, we need to simplify our lives. So how do we achieve excellent results? Well, proper patient selection, and by that I mean we need to offer this technology for patients who really want to be free of glasses. Someone who has no interest in not wearing glasses, it's not going to make sense. So for someone who's motivated not to wear glasses. We need excellent biometry. We need to make sure there's a good topography, tomography, and tear status when you're dealing with AT IOLs. We need to make sure that the surgical technique is excellent. And we also need to have a very well-documented informed consent. I mean, what happens if a posterior capsular rupture occurs and you can't use that lens? Patients need to know they've got a higher chance of needing YAG for PCO. They need to know about dysphotopsia. So today you've heard we're speaking 3 international speakers, all with a lot of experience, especially Sheraz and Francesco have a huge experience in multifocal lenses over a very long time. And what we're going to do, each speaker is going to give you an overview of their approach to patient selection, and is then going to give a case study of a good candidate for an AT-IOL. He's then going to look at a poor candidate for AT-IOLs. And we've separated the poor candidates into different segments. So talking to patients, we spoke about this last time, but for those who didn't get it last time, or didn't see it last time, whenever you're doing light splitting or you're doing something with a lens to give you multiple zones, there's going to be a level of dysphotopsia. And generally speaking, the more full the range, the more dysphotopsia. And the less glare and halos you have, the less range you have. So it's really important that patients understand this compromise. And that's why it's important to have this discussion and not only select the patient correctly from the point of view that the anatomy is good, but also that they understand what you're trying to achieve. And then one particular group, I brought this up separately because I think if you're starting out with this, maybe this is the one group to avoid at the start. But myopes, it's a trade-off, there's a compromise. They can already see up close. So when you treat them, you're improving their distance, and they can still see up close, and maybe not as well as before. And so education is very key for them. But with hyperopes, when you treat them, you're improving their distance and their near, and for that reason, they're far more inclined to accept the compromises of multifocal IOLs. Why do we continue to do it? We ended up with this last time too. Patient satisfaction is our top priority. We want practice growth. And it's very rewarding for a cataract surgeon to now have patients being very thankful for the refractive outcomes. So thank you very much, and I'll hand back to you.
Thank you.
徐主任
Dr.
还
Cummings
请您，sorry，Dr. Wong，徐主任还请您翻译一下那个 Arthur Cummings 教授的讲话，可以吗？
好的。Good evening, Professor Arthur。各位教授，大家晚上好。今天Arthur 教授主要说，今天呢，我们一个是在患者的选择上会进行一个讨论。那么如何选择合适的患者，以及如何避免不适合的患者。目前就当代的屈光手术呢，已经是一个非常成功的一个手术。白内障手术呢，也属于屈光性手术，也属于屈光性的手术了。非常的
徐主任，不好意思，您那边信号可能不太好，我们听不太清楚，断断续续的。
Okay, I think due to a bad connection, I think we move on first. We can actually probably answer some question at the end of that if there are any question. 我觉得现在我们应该继续因为你的那个网的connection 不大好。如果你们这个我们大家有什么问题的话，你可以在这个讲课过后，你们可以写在那个 chat box 上，可以问你的问题。I think we move on to the real case-based lectures. We have 3 speakers today, and each of them are given slightly more than 10 minutes for each. And I would like to invite Dr. Francesco Carones from Milan to present us his case.
Thank you very much. I'd like to thank, first of all, Daya for organizing this symposium, and also Arthur for inviting and presenting to such a huge audience. So what I'm going to share with you are some tips and tricks as regards the selection of patients, specifically regarding 4 different issues, as you will see in a while. Let me also make some financial disclosure, some consulting from some of the companies involved with presbyopia correcting IOLs. So how is the ideal patient? Well, you can read here some of the features that an ideal patient should have in terms of age, in terms of the status of the cataract, and then there are other points related to motivations. We know that a slightly hyperopic patients usually is going to be happier after surgery than a myopic one, as Arthur was mentioning earlier. But basically want to have, let's say, an otherwise a healthy eye patient with all the features, all the characteristics that are aligned in having only the cataract as the real situation, the real pathology, as you see, like in this collecting example. There are some eye conditions that may suggest a downgrade from a high-performance IOL to correct presbyopia to a different personalized solution. And here there are some of them listed. We will go through all of them during this symposium, and I'm going to focus on just 4 of them, as I said, issues related to the corneal health, issues related to the lens health, issues related to high-order aberrations coming from the cornea, and all related to kappa and alpha angle. Let me start from the corneal health, meaning the status of the corneal endothelium. The corneal endothelium may have, problems in terms of Cutara or Fuchs syndrome. And what happens is that the light going through the endothelium gets some kind of scattering that adds to the scattering and to the contrast sensitivity reduction that especially diffractive high-performing IOLs may have. And this usually ends up with some sort of visual acuity reduction, also contrast sensitivity reduction, as we said earlier, and an increased chance of having night dysphotopsia. Non-diffractive high-performance IOLs may be a better viable option in this case because of the lower, contrast sensitivity reduction that they induce, but we also know that they are less performing. Let me show you an example. Here is a case of mine where I was not very happy with. It's a case that has been treated a few years ago. You see here a woman with cataract. And this woman was very motivated in having spectacle independence after her cataract surgery. Actually, her husband had a presbyopic correcting IOL implanted, and the patient was very happy. So this patient, I'm not saying kind of forced it, but she was very insisting about having a presbyopic correcting IOL. And this is what I did. I implanted her with a full range of focus diffractive high performance IOL, and you see the numbers are not very satisfactory. So the uncorrected visual acuity as well as the best corrected visual acuity was not ideal. The patient ended up reporting some very boring and annoying dysphotopsia at night. She has difficulties at reading at all distances, and unfortunately, in these cases, spectacles don't help at all. She has a fluctuating vision, and basically, she is not happy. She never decided to have the IOLs explanted, but as I said, that was one of my failures. The patient was not happy with the result, and you see from the corneal topography analysis that nothing was wrong with her, even at the assessment of the centration of the trifocal ion. In this case, this lens was very well centered, so nothing else but the scatter from the endothelium giving her this some sort of unsatisfaction. Another point may be the low endothelial cell density, which is not a problem per se. But obviously, if the density goes up too low, there may be problems like edema and sumedema, and also changes in the corneal thickness. And especially changes in corneal thickness are a problem if these changes are asymmetrical, as you will see in a while. Again, diffractive high-performing IOLs are more challenging because of all that it is implied with the diffractive pattern, and maybe again a non-diffractive IOL, more like a refractive one, may be a more viable option. Here is the case that I want to present you. This case was not treated by myself. I saw her in January 2021 after having received bilaterally a full range of focus high-performing implant, diffractive one. So you see here, the left eye was fine. The right eye had a significant edema, and this is why I saw her at some point on her story. And here is her status 4 months after surgery. So still a not very satisfactory best corrected visual acuity and uncorrected visual acuity as well. But the patient was particularly unhappy because with this eye, she's reporting a lot of halos, double imaging, and a poor vision. And you can see here from the ocular, from the anterior segment OCT, and from the scans, what is the problem. So in the first scan of the OCT, that's the horizontal scan, you see that the thickness of the cornea is even all over its surface. If you focus on the lower image of the scan, you see that the part of the cornea which goes on the right is actually thicker than the other one. And this is the superior part of the cornea. And you see that the superior part of the cornea is that where also the thickness as measured with the OCT scan is higher. You see there is this kind of asymmetry, and the patient is complaining about this induced high order aberrations by this anomaly in thickness, this asymmetry in thickness. Let me tell also briefly about the lens health status, not because, again, per se, it's a problem, but in all cases where the centration of the IOL, like in the case that I'm pointing you off, is not trusted to be maintained over the middle and long term, well, a malposition of the IOL and a displacement on the IOL may result into a or a suboptimal result, like in this case where the entire capsular bag actually was misplaced, and obviously the ocular performances were reduced quite significantly. Let me move to the high order aberrations coming from the cornea, and basically, what I think is more interesting to discuss very briefly are those coming from refractive surgery. You see on this image two extreme cases, like a decentered myopic treatment, as well as an extreme hyperopic treatment. And obviously, these cases are not the best to be implanted with presbyopia correcting IOLs, just because of the issues that you can read there: contrast sensitivity reduction, a poor image quality, an increase in night dysphotopsia, and again, maybe a non-diffractive high-performance IOL may be more forgiving, but in cases like so extreme, I will not suggest to go with a presbyopia correcting IOL at all. Let me present you a different case where the decision to implant an IOL to correct presbyopia was made by myself. Here is a case of patient who had LASIK a lot of years ago for a plus 3.5 diopters correction. The patient developed cataract while time was going on, and the patient was very motivated and having a spectacle independence. So, analyzing the status of the cornea, we just realized that the cornea curvature was obviously steeper, but even symmetrical, no issues at all. You can see also here that the evaluation of high order aberrations were showing us a little bit of negative spherical aberration, but nothing significant. So in this case, I decided to implant bilaterally a non-diffractive let's say, increase the range of focus IOL, if I remember correctly, in this case was a Vivity, and the patient turned out being very happy with a very nice uncorrected visual acuity and a reading ability that was a little bit increased by the negative spherical aberration residuated from the hyperopic treatment the patient had. So the patient in this case was very happy. Finally, very briefly, let me talk about the kappa and alpha angles. You know that we can measure with the kappa angle, while with the alpha angle, not being able to really measure the visual axis, more like a guess, assessing where it is. So we like to refer more to the kappa angle. Kappa angle actually can be measured also with the corneal topography or with OCT scans, as you see in this case. That's the same example of the drawing that you see there on a real patient. What is the method? The method is that if the angle kappa, so the difference in between the center of the pupil and the center of where the light is supposed to go through is wider than a center magic number, and usually 0.5 millimeters is what is considered the magic number, there may be an increased risk of night dysphotopsia, again, reduce the contrast sensitivity and the poor image quality. So these are, again, cases where you may want to think a little bit longer about the possibility of implanting a high-performing IOL, especially if it is diffractive. when assessing the kappa angle, you also have to consider that there is a possibility for adjusting for the IOL positioning in relation to the kappa angle. And I'm showing you this example. If you look at the aberrometry, this eye looks significantly decentered in terms of the IOL. Actually, if we look at the real image with a cycle camera, with a posterior reflex camera, you see that the IOL was intentionally decentered in relation to the center of the pupil to match more the kappa angle of the patient. So this is something that can still help you centering the challenging cases if you have the possibility for compensating by the adjustment of the position of the IOL to match the kappa angle, and then having a better visual performances and maybe reducing the complaints that the patient may have if this matching is not really made. So again, just to summarize, you will hear about other watch outs. So these are the 4 ones I'm suggesting you to pay attention to. So the status of the corneal health, again, the lens health, the high order aberrations coming from the cornea, and the issue related to the kappa and alpha angle. Thank you.
Thank you, Francesco. So Dr. Qian will do the interpretation for your talk. 钱博，那您就开始吧，我共享他的课件，然后您来给听众老师们翻译一下，好吗？
好的，好的。Thank you, Dr. Francesco Carones。今天Francesco Carones 教授呢讲了一下，我们怎么样对于一些高端人工晶体的病人进行一个选择，是一个怎么样的标准。高端的人工晶体一般它的理想的患者的这是一个利益冲突的声明。高端人工晶体的它的患者的选择标准呢，一般是它有一个年龄的标准是60到70岁之间，拥有双眼的白内障，患者呢是需要有一个比较强烈的手术的意愿，屈光状态呢最好是有一个轻微的远视，他的性格呢一般要是比较积极开朗的一个性格，也有一些就诊渠道的一些要求，最好是一些其他的患者就转介绍而来的。那么如果这个来求诊的病人他有一些以下的问题呢，那么装高端的人工晶体之后的手术效果可能就并不是那么理想了。比如说这个患者他有一些严重的一个眼表的一个疾病，比如说有角膜的一些问题，有泪膜的问题，或者有角膜的不规则散光，既往的角膜手术屈光史，角膜内皮营养不良，比如说卡帕角或者是阿法角过大，瞳孔过大或者过小，玻璃体或者黄斑有问题，比如说这个病人有黄斑前膜等等，这些疾病呢都会造成高端人工晶体手术效果会不理想，或者呢这些病人需要选择一些其他的一些个性化的手术方案。那么我们具体要关注的因素呢包括以下几个，这里Francesco 教授呢介绍了几个因素。第一个是角膜的一个情况，还有晶体的一个情况，第三个是角膜的一个高阶相差，还有卡帕角和阿法角的一个情况。那么在角膜的一个方面呢，我们尤其是需要关注一个角膜内皮细胞的一个状态。尤其是对于一个Fuchs 角膜内皮营养不良的患者，由于角膜的患者的这些患者的角膜后弹力层，它会有一些滴状的一个赘生物，它的光线穿过角膜内皮细胞呢，就会发生散射，造成手术之后的视力的下降。换下一张 PPT。造成手术之后的视力下降，视觉质量不佳。会有一些夜间的眩光啊，之类的等等。如果这个患者的就是这是一个教授讲了一个例子，这个患者是Francesco 教授自己做的一个病人。这个患者他有强烈的意愿去做一个 高端的一个多焦点人工晶体的植入，但是他的双眼的视力，右眼是裸眼和矫正视力都是0.5，左眼也是0.5，他呢希望就是达到一个全程的一个不带镜的一个视力。但是他是一个就是Fuchs 角膜内皮营养不良的患者，虽然说他是一个稳定期的病人，但是他做完这个多焦点人工晶体植入之后呢，他依然感觉到了就夜间眩光很严重，阅读困难，也就是说他看近视力非常的差，而且戴了眼镜也就是矫正了一个视力之后呢依然不管用，同时呢会有一个视力的波动，所以这个病人术后的效果是不好的，也就是他是不满意的。这张可以再往后，再往后，对，那个第二个呢，就是一个角膜的内皮的一个情况，就是角膜的内皮呢，就是内皮技术它如果过低的话，它本质上呢不是一个高端白内障手术的一个绝对禁忌症，但是呢，问题就在于手术之后发生角膜水肿的几率是会比较高的，而这个角膜如果水肿的话，就会造成角膜厚度的一个就是整个角膜厚度的不均匀，而这种变化呢也会造成高端晶体手术之后的一个效果不好。之后呢，教授又举了另外一个病人的一个例子，下一张 PPT。这是一个81岁的女性的病人，她呢是有角膜内皮的一个就是角膜内皮不好的，可以从这个角膜地形图上看出来，她的就是她的右眼，她的右眼视力是就是她的右眼呢给她做了一个白内障的一个手术，也是装了一个高端的就是双焦点人工晶体，结果呢她的视力呢是有裸眼是0.8，矫正是有1.0，但是她这个病人呢依然感觉到她有光晕啊、重影啊、视力差，就是手术效果她是觉得不好的。下一张 PPT， 这是一个她的那个就是眼前端的一个，可以看到它的角膜内皮，就是它的角膜是上方这一部分是有肿胀的。下一张 PPT， 对，接下来是一个晶体的健康的一个情况，就是比如说这个病人如果会有那个假性囊膜剥脱，或者是有悬韧带损伤，晶体半脱位等等情况，这些疾病呢都会造成手术之后植入高端晶体的位置它是不居中的，造成一个手术效果的不好。下一张 PPT。接下来要讲一下的是角膜的高阶相差。角膜的高阶相差呢，它分为手术之前已经存在的和屈光手术之后的造成的两种情况。那么角膜高阶相差的一个增大呢，也会造成对比敏感度的降低，视物图像的质量比较差，夜间眩光等等情况。对于这种患者呢，植入非衍射型的一个高端人工晶体，可能包容度会更好一点。下一张 PPT。接下来那个教授他举的一个例子是一个68岁的男性患者，然后他呢是有着大量的那个工作的要求和户外运动的一个要求，然后呢他的右眼视力是矫正和裸眼和矫正都是0.7，左眼呢都是0.5，是一个3级合。他呢也是希望能够恢复视力，能够脱镜正常的生活，就是希望能够脱镜嘛。下一张 PPT。这是他的一个左眼，可以看到就是高阶相差还是就是角膜的高阶相差还是比较高的一个。下一张 PPT， 这也是一个角膜基因图。下张 PPT。结果对于这个病人呢，就是对他植入了一个就是非衍射型的一个晶体，然后之后呢，他的术后效果还是不错的，他是就是夜间的视觉质量尤其是比较好的。下张 PPT。接下来就要讲一下那个卡巴角和阿法角。卡巴角呢是指的是瞳孔轴和视轴的一个夹角，阿法角指的是一个光轴和视轴的一个夹角。下张 PPT。现在呢一般认为两者的角度大于0.5毫米呢，就可能导致人工晶体的它的位置居中不理想，会引起手术之后视觉质量的不好。这个时候呢，下张 PPT。 这个时候呢，就是教授提出了一个方法，说就是其实对于一些卡巴角过大的一些病例，是不是可以在手术之中，通过调整人工晶体在囊袋内的位置来补偿这个卡巴角过大的一个情况。这样的话呢，对这些就是具有挑战性的病例，可能会有一个比较好的一个手术效果。以上就是Francesco 教授介绍的4种就是我们需要注意的在筛选高端晶体病人的一个情况。谢谢。
谢谢你 Dr. Chen. Thank you. I think in the interest of time, we move on to the next presentation by Dr.Sheraz Daya. Remember, you can ask your question at the end of to the panel at the end of the session, of our session today. 现在我们就请Dr.Sheraz Daya 来讲他的课程。Dr. Daya?
Yeah, I'm just trying to share my screen. Can you see my screen there?
Thank you. Yes.
Somebody's dog is on the loose. Oh, yeah, thank you very much for inviting me to speak at this conference and the second in the series. It's a real privilege and great to be accompanied by my peers, Arthur Cummings and Francesco Carones. So I was asked to talk about the importance of corneal topography and the ocular surface in the context of advanced technology intraocular lenses. I get this advance the screen here. These are my financial declarations. I work with a lot of companies that manufacture some of these sorts of lenses, and it's a privilege to work with them. Now, we've already alluded to this, but I just want to go back to first principles. In order to obtain good vision, it doesn't matter whether it's with an advanced technology implant or a monofocal implant, it's a marriage between good corneal optics and the implant. So even more so when it comes to complicated optics like those in multifocal lenses or advanced technology lenses, it's really important to keep the variables constant, and corneal optics are vital. So if you take a look, this particular topography is not good for a patient undergoing advanced technology IOLs. The consequences of this, if the ocular surface or the corneal shape is not correct, they'll get poor vision. The optics do not combine, or they may get fluctuating vision if it's, for instance, the tear film. Biometry can also be challenging. Getting an accurate outcome is dependent on good biometry, and there can be considerable IOL miscalculation in this sort of situation, and both patient and surgeon wind up becoming unhappy. So what are the causes of irregular stigmatism? Again, working from principles from front to back, if one takes a look at the surface of the eye, there's the tear film, and then the epithelial surface, and then on the subepithelial surface can influence the corneal regularity as well. And then you've got the stroma. Now, this is a condition where there's a tear film problem. The tear film problem here is poor closure of the lids. They have blink lagophthalmos. And you can have a variety of causes of dry eye, but they'll all influence the ocular surface. In this particular case, you can see the line where the lid closes and then opens back up again. Now, this particular person is prone to dry eye from exposure, and in all probability, they will have a problem with both intraocular lens biometry as well as their surgery afterwards in terms of outcome. So looking at the tear film, it's very important to understand that when you've got an abnormal tear film, this is an osmolarity study performed by Alice Epitropoulos, and it's very good. It illustrates that if the tear surface is abnormal in terms of osmolarity, then there's a huge variation in biometry results in the orange dots compared to the blue dots. So this is worth keeping in mind. You need a good ocular surface in order to get good readings. This is a patient with epithelial basement membrane dystrophy or anterior basement membrane dystrophy. You can see the maps on the surface there. This person is not a good candidate for an advanced lens unless this problem is addressed. And often what we do is we treat the underlying cause, which I believe is lid disease, and we remove the epithelium, allow it to grow. If it grows back normally without these epithelial islands, then we can go ahead and do biometry and treat them. These are other extreme cases. This is a patient with PRK haze on the left-hand side, and somebody with Salzmann's nodular degeneration on the right-hand side of the screen. So these are irregular corneas as a result of subepithelial problems. This is an irregular astigmatism from a stromal problem. This is keratoconus in a patient. Actually, this patient has scarring as well from the keratoconus. And again, these are not patients suitable for advanced technology implants. Now, when it comes to irregular astigmatism, assume the tear film is normal. Assume the epithelium is normal and subepithelium is normal. What about the stroma? It's clear, but they could wind up having asymmetric astigmatism, which can be of two different sorts. It's either there's an asymmetric bow tie and the astigmatism orthogonal. By that, we mean it's in one straight line, or it could be non-orthogonal. Because if you take a look, this is the astigmatism in this direction superiorly and then inferiorly. They're not in one straight line. So this can be a bit of a problem in these patients. It's not to say they can't be treated, but you have to consider toric lenses and the magnitude of this problem. On the right-hand side, the non-orthogonal astigmatism with this patient has keratoconus, they're going to have coma, high-order aberrations that Francesco Carones already alluded to. And those higher-order aberrations may not mix with increased and full range of focus lenses. So it's very important to make a diagnosis of irregular astigmatism at the time of clinical evaluation. And we do this by using topography, placido-based topography, and also by clinical examination. This is sort of diagnostics we use. This is an excerpt from the Daya printout on the OPD3 scan from NIDEC. I'm a consultant for them. I'll declare my interest there, but I believe this is a good printout that gives you a lot of information on the ocular surface and what's going on overall in the eye. When we evaluate the patient, we look at the corneal shape, clarity, surface, we put fluorescein in, and we look for lid wiper action, how tears distribute across the cornea, and also good closure. That's really important. You see, both these patients have problems with the ocular surface. This is the topography. We use reflective topography, placido-based, and this illustrates the issue here. You can see this is surface regularity index is in red. This is an irregular cornea, and this is not suitable for an advanced lens. Moving forward, what sort of placido systems do we have? There are a variety of them out there, and they're all very, very good. Some of them combined with aberrometry, which I find very useful. That's the OPD3, which I've mentioned, the eye trace from Tracy Technologies, and the KR1W, and I'm sure there are others as well. The three-dimensional diagnostics are useful in looking at the corneal shape, looking at elevation, looking at the posterior cornea, and looking at thickness. This all began with scanning slit evaluation, which is now being superseded by Shyan using the Pentacam or Galileo. And now we've gone one step further with OCT measurement of the cornea using the Cassia, the M39 from CSO, and the Anterion from Heidelberg, and the ACE from Bausch & Lomb. The HD analyzer is a very, very useful tool for evaluating the eye, because it takes into consideration the whole ocular surface, the ocular performance, the tear film, the cornea, the lens, and the vitreous. And what it does do is gives you this ocular scatter index, and you can see they've got a nice scale here that shows you whether it's good or bad. This happens to be very, very good at 0.7. But it also has the ability to look at the vision breakup time. So a patient blinks and they keep their eyelids open, and the point spread function is evaluated and plotted, as you can see here. This person has a very good tear breakup time. But take a look at that's the ideal case. And you can see that here. This patient has good surface regularity indices, all in green, good OSI, and a good tear breakup time. If you take a look at this patient, this is not an ideal patient. This sort of sums it up. This is a patient with an irregular tear film, punctate epithelial keratopathy, and they even have anterior base membrane dystrophy. So this is a person who would need a lot more tuning up before undergoing vision correction surgery. You can see that streaky tear film there, not good at all for undergoing advanced technology intraocular lenses. And you can see they've even got a chalazion, so they've got meibomian gland disease with a blockage of a gland. So that's not a good case. This is another not so good case where a patient's had previous laser eye surgery and they've got a decentered ablation. And this is an HD analyzer of another not so good case with a point spread function that's very, very poor, with an OSI of 5.8. And this is because the tear film is terrible. So this is the same patient, 5.8, and it's the tear film that's the issue. We've got to fix the tear film before you can consider an advanced technology implant. So with dry eye, you need to evaluate the cause and treat it. And once the surface is stable, repeat the lens calculations, and then consider if this patient really is stable and suitable for an advanced technology lens. With anterior basement membrane dystrophy, as I've already mentioned, you can peel off the epithelium. We can do this with alcohol delamination, as you can see here in the video. And that usually suffices. And at least that's your baseline. So I usually wait 6 weeks before I go ahead and reevaluate the patient. And if they haven't had a recurrence, and they usually don't, I will go ahead and treat them. But I watch them. And if they have problems in the future, although I've not seen any, then I might have to consider debriding the epithelium again. But I find an association with this disease and lid disease. So I treat the lid disease at the same time. So this is the patient that we just did in the previous slide. This is what they look like preoperatively. This is the epithelial thickness map that shows a high level of irregularity. And this is then postoperatively. You can see the post-epithelial removal at about 6 weeks. They've got a good surface regularity index of 0.5. That cornea is completely smooth, and they're suitable now for advanced technology implants and also surgery. This is a patient that had peripheral Salzmann's nodular degeneration, as you can see. Now he was +6, -4, and they sent him to me for a toric multifocal lens. I said, wait a minute, this guy is not suitable. We've got to take care of his ocular surface. We've got to take care of his Salzmann's nodular degeneration, and then we could consider it. So this is what we did on him. We took his Salzmann's nodules off, and what do you know? After surgery, his refraction changed to +1.5, -1.25, giving him a vision of 6/4.8. He turned around to me and said, I don't need any surgery. I don't want any lens implant surgery. I'm seeing really well right now. And he went from a hyperopic astigmatic correction to almost plano. So just a simple thing like this can look after those patients. He doesn't need an advanced technology IOL. He may want one in the future, but as you can see, we've repaired the ocular surface and repaired the irregularity. This is the same patient. You can see here his IOL master shows it requires, well, just say we were going to use a trifocal lens, 24.5. This is before surgery. He would need a toric correction too. And if you look at also his average keratometry is 34 diopters. But after removal of the Salzmann's nodules, the power went down to 20, and his average keratometry increased to 42.4. What a difference in keratometry just by looking at that surface there. So that's repairing the ocular surface. What about patients with non-orthogonal astigmatism? Keratoconus is the most commonest cause of this. They can get foam for keratoconus, as you can see here. And this is another case of non-orthogonal astigmatism. I find these patients quite complicated to deal with. It again, a lot depends on the surface regularity index and the asymmetry. And you can see this is it here. Looking at those two parameters there, they're abnormal. And this is what they have, coma. You can see that quite clearly over here. This is not a good patient for an advanced technology implant. So irregular astigmatism in advanced technology implants, really they're not good, they're not compatible with good outcomes unless you have a means of fixing the irregularity. Managing these patients really requires evaluating the source of the problem, addressing it if it can be addressed, reducing the magnitude of irregularity, reevaluate, redo the lens calculations, and when their irregular astigmatism is compatible with good vision, then you can proceed with an advanced technology implant. Thank you for your kind attention.
Thank you, Dr. Sheraz Daya. And then can we have the translation?
Yes, 高院长，还请您帮忙翻译一下，然后我来共享屏幕，好吗？您那边静音了。您开一下声音好吗？
Okay. Thank you very much. Thank you, Dr. Sheraz Daya, and really very wonderful presentation. I think perhaps maybe I may missing something, and here I ask Dr. Wong and Dr. Chen if I make mistake, please help me. OK, thank you. 那个 Sheraz Daya 教授呢，他讲的这个功能性人工晶体，在这个角膜它的这种在选择之前做角膜地形图，还有就是评估它的眼表的重要性，就是利益冲突的说明。这里呢，他提到这个就是好的光学的系统是获得这个好的视力的一个前提。像这种就是说这种在这个人工晶体的选择和这个角膜的光学之间呢，它是一个相辅相成的。如果是两个人的这两个这个指标的搭配，最后得到一个这样一个结果的话，那它显然是不是我们的初衷是不能去选择这个功能型的人工晶体的。Next slide, please. 如果是这个眼表比较差或角膜形态有问题的话呢，它一个是视力不好，视力波动，然后呢引起这些角膜生物学的测量会出现错误或者误差。好的 ，Next one, please. 这个不规则散光呢，它的原因有很多，从前到后，有这个一个是最表层的泪膜，然后上皮层、上皮下和基质层。泪膜呢，它是有可能会引起它的原因呢，一个是分泌的不足，然后就是蒸发和炎症。这种不规则的泪膜，像它所表现的这个右边这个图呢，它可能是暴露引起的。泪膜对这个生物测量是非常重要的，尤其是我们通过这个泪液的渗透压来看到，如果是高渗透压下，也就是不健康的这种泪膜呢，它会当你在不同时间点来测量它的这个生物测量的话，有很多是会造成两次之间的差异非常的大，不管是注镜还是人工晶体度数的计算。像这个呢，它是一个不规则的上皮型的一个上皮层的变化，这个就是叫前基底膜营养不良。像这种病人呢，是可以经过治疗之后再考虑这个功能型的人工晶体的。像前弹力层的这种，包括这个 Salesman 结节，还有这个前弹力层的疤痕，以及 raised buckler 这种呢，经过评估和治疗，有的也是可以选择功能型的人工晶体的。这个呢是不规则散光，这种不规则散光是来自基质层，我们可以看到它的一个扩张，还有这个地形图的明确的疤痕，这种呢是显然不考虑功能型人工晶体的。这个角膜形状呢，是一个是它是就是不规则散光，一个是它是不对称的，再一个就是非垂直的，也就是说这两个的它的扁平和陡峭轴之间的夹不是90度，这种呢也是不考虑功能型人工晶体的。就是当我们发现不规则散光之后呢，需要进行临床的评估和生物学的角膜地形图等等的测量，来给它一个正确的评估。下一张，那临床评估呢，包括裂隙中的观察，它的形状、透明度和表面的，然后做染色。这个染色呢，然后这个患者做睁眼闭眼的运动，观察荧光素的分布来评估。好，下一个。像这样一个患者呢，他是这个角膜地形图，我们明显的看到中间这个先是这个中间我们可以看到它是红色的，然后下面这个 SDR 和 SII 还有 SAI 这个值3个值都是爆红色的，这种呢显然也是不符合做这个功能型人工晶体的。对它的诊断有几种方法，一个是 Placido 系统的，再一个它还有联合其他的一个做包括这 OPD、iTrace 还有这个 KR1W， 这些都很重要做3维的诊断方面呢，包括一个是这一个角膜的高度、角膜的后表面，也是角膜的厚度，通过这以下的这一些仪器设备进行观察。这个是HD Analyzer 呢，这是个欧卡斯，它对评估整个眼球，包括从前就是泪膜、角膜晶体以及玻璃体，都是一个非常重要的，尤其是对这个视觉 这个功能的判断是非常的重要的。这是分享的一个这样一个案例。看这个案例呢，它是一个是角膜地形图的提示，它的这些指标还是不错的。然后呢，这个第二张这个 HD 就是这个欧卡斯的检查呢，它这个 OSI 值是 0.7，还有它这个模拟的这个视觉的质量图也是非常的好的。然后对这个 BU 它在不同时间当它闭眼然后睁眼，维持睁眼状态，在10秒内呢，它这个 BUT 的时间在这样一个它的这个视觉的效果也都是维持一个非常稳定的状态。这个呢就是比较好的一个状态，比较适合装功能型的人工晶体。像这样一个OK， 这个OK，next slide please。这个呢就不是很好的这个刚才前面那个荧光素染色呢，它在讲的也是一个不太好的，不适合装高端晶体的这个呢也是不适合呢。为什么？一个是它角膜的一个是不规则，然后在 next slide， no， 前一个对。像这种呢，它的 OSI 值 5.8 非常的大，也是不适合。然后呢，就是在不同的时间内，它这个视力的波动范围非常的大。好，下一个。那么遇到干眼的呢，我们这种干眼的成因，然后我们要对它进行一个评估和治疗。等它一旦的这个干眼的指标稳定之后呢，就可以再次重复来计算人工晶体，来评估它是否适合。这个就是刚才他说的一个前基底膜营养不良的一个患者，这种呢，这个病理，他的病理我就不介绍了，就是他给他做一个在角膜表面给他点上酒精，然后软化之后，用这个刮子把这个上皮给刮掉，刮掉之后呢，对，下一张，然后就看到这同样一个病例，他在做这个手术之前。这个角膜地形图的表现，它是这个角膜的各项的指标都是红色的，然后中央都是可以看到它是不规则的，这个高度是很变化比较就是这个开始是47点几，显然从这里看是不适合装高端晶体，但是他给他做了这个上皮的刮除之后，6周重新再做这样的生物测量，就发现以上这些指标都变得非常理想。那么这个患者就适合装高端晶体。好 ，next one， 这个呢就是一个这个 salesman 的结节样变性，它同样的也是把这个上皮给刮掉。这种这个 salesman 对刮掉之后再做检查之后也是比较理想。好 ，next one， 这是同样的，就刚才这个 salesman 结节的这个患者可以看到这个黄色的呢，这种是在手术之前做的，可以看到它的这个开值是38点几，然后它计算出来的人工晶体度数是24点几，然后在做完这个手术之后，好 ，next one， 就发生了变化，在上一张。对，做完这个手术之后，它的数据发生了很大的变化。一个是它的开值这个趋于正常，然后计算出来的人工晶体度数比术前小了4个 D 多。好 ，next one， 这个呢就是一个非垂直散光的这种情况最常见的是圆锥角膜，可以看到这个地形图所表现出来的这种像这个呢，显然也是不适合装高端晶体的。好的，这一个是也是在这个在做的检查之后，可以看到它这个角膜的各项指标，它的这个一个是规则指数和这个对称性指数，它都是红色的然后这个也是不适合装的，好，不适合高端晶体的。那么最后强调呢，就是这个对装高端晶体之前要慎重对待这个不规则散光。那有的呢，就是对这一部分发现的这种不规则散光要做一个评估。如果 考虑到这种不规则散光，可以装了高端晶体之后有好的视觉效果的话，是可以考虑去使用的。那所以呢，就是要对它进行一个管理，评估这个问题的根源到底是哪里，然后有的呢要做相应的治疗，治疗之后有可能会有的呢是可以减少不规则散光的这个度，然后再去做。如果发现这种不规则散光尽管存在，但它还有可能植入好的晶体之后会获得好的效果的时候，就去计算这个人工晶体度数和做这个手术。好的，谢谢。
谢谢你 ，Thank you. Remember, you can ask your question at the end of the discussions. So I now want to invite Dr. Arthur Cummings to present his presentation. Dr. Cummings.
Right, thanks. I'm just waiting for the opportunity again. There we go. It should be good now. Francesco and Sheraz, those were two fantastic lectures. Very, very good indeed. And I must say, some real pearls there and amazing surgical cases. Sorry, I'm not sure what's happening here. Here we go. All right, so it's in very much the same vein as what you've heard before. So I'm not going to waste too much time. Just my disclosures. We're speaking about who the right patients are and good cases and bad cases. My apologies, I think, no, I am right. So we need patients who have a regular cornea, as you've heard very eloquently, where the ocular surface is good, there's no lens pathology, and then also where the retina is healthy. There's no sign of epiretinal membrane or diabetic retinopathy, age-related macular degeneration, or optic nerve issues. So as far as the cornea goes, you've seen some very, very good cases of regular versus irregular astigmatism. I'm going to speak a little bit about the BAD display and the Fourier analysis, and then also the fact that on occasion, you're going to have to do a laser vision correction enhancement of a case. So you want to, before you do a lens procedure, just know that the case is going to do well. So here we see irregular astigmatism, and this patient should do well with multifocal IOL. And we see a case like this with a decentered ablation, it's likely not going to be the case. It'll be more difficult to get a good result. A case like this looks absolutely perfect. Everything looks fine and regular, yet when we do the BAD, we find there's a value that suggests we should be careful of LASIK. So that's something you want to know up front before you do the procedure, just in case you have to land up doing a laser vision correction procedure. And this case too, looking very good. And what we routinely use when doing these cases is you look and see what the indices find with a Fourier analysis. And they will always highlight a problem. In this case, there's no problems at all. So this patient should do very well from a corneal point of view. There should be no surprises. And then Francesco showed very nicely the value of epithelial mapping and the MS39. And again, we like doing this too to make sure that there's nothing that's hiding that's almost subclinical. The Fourier analysis is very, very useful. And we can see this image on the left where you can see the topography. There's a bow tie, but it's lopsided. And you can see that results in significant coma. And a patient like this mightn't do very well with a advanced technology IOL. The tear film, we like to see a normal osmolarity, a normal ocular scatter index, and a normal tear breakup time. And we saw this earlier. This is a case that you'd love to do. The ocular scatter looks good, the tear layer is stable, and optically it's good throughout the 10-second cycle. What about the lens? We've looked at this already, but we need to have a good capsular rhexis, not any posterior capsular tears, no subluxation of the lens, and intact zonules. Now, the fundus, as I'll probably spend most of my time, is we want a normal OCT, no macular pathology or limited macular pathology, no epiretinal membranes, or again, limited. It comes with experience, no AMD, and no optic nerve pathology. So a case like this is perfect. It's obviously a very young person. It's a 26-year-old. So nerve is perfect, macula is perfect. This patient, if this belonged to a 60-year-old, would have no problems from a retinal point of view. And in a case like this, things also look perfect. We often use the shadowgram to give us an idea of what the optics look like too, and there might be a small little floater over here on the right eye. And optic nerve health very good with normal nerve fiber layer thickness and reasonable symmetry between the two eyes. So those are all good cases. So good case study, normal OCT, normal cornea with low higher order aberrations, good tears, and a low tear film ocular scatter index. So I want to show an additional way that we use the HD analyzer. So this particular patient over here has an ocular scatter index of 1.5. And what's interesting, if this patient doesn't have complaints of glare, which is common, they mightn't have any complaints of glare with the early cataract, you can almost know up front that if you implant a multifocal IOL, and normally the OSI of multifocal IOLs is around about 0.8 or 0.9 in my experience on our device, they're not going to complain afterwards. But a patient like this, who has no complaints or has a very low ocular scatter index, they may land up afterwards complaining of ocular scatter, even with a perfect procedure, because the ocular scatter would tend to increase to around about 0.9. So it's just a very handy tool to help you navigate that issue. We often see patients like this when they first come in and they're just not suitable for surgery, and we'll start working on the tears, and we can see the tears are improving, but they're still not ready. And eventually, once they look like this, then they're ready for their surgery. And as Sheraz pointed out very nicely, they're not just ready for their surgery, but they're not even ready for their diagnostics. You don't want to base your surgery on diagnostics that are not valid. This device is the eye trace. We heard about the OPD3 as well as the KR1W. And this device is very helpful, especially from the patient's point of view. For me, it's very nice, the eye trace, because it makes these complex optics, it makes it quite simple. But I'd show a patient, here's the impact of your lens. We're going to correct this. And on the left over here is what your corneal impacts are currently. So once we make this internal optic perfect, instead of finding a completely perfect E on the right-hand side, your total optics, we're going to still find some blur from the corneal optics. And as has been pointed out before, is adding blur in the corneal optics to a multifocal IOL is not the best idea. This is always a very nice way to show up front exactly what we expect. So here's a poor case study. And Sheraz and Francesco looked at ocular surface, cornea, angle kappa, these types of things. I'm going to look mainly just at the back of the eye. So here's a case here where on the shadowgram, we see there's some clouding over the macula. If we can determine with other devices that this is actually due to the lens, this patient's going to do really well. If that's due to something else like a vitreous issue, then it's something to be careful of. And a vitreous issue might be nothing other than a posterior vitreous detachment that's still just premacular and maybe bothering people. We recently on the RSA forum had a long discussion over many weeks of people implanting multifocal IOLs with patients who were very unhappy. And all of these in common had the fact that they had floaters. And once their floaters were removed, they were very, very happy. So it's one way of addressing it preoperatively, make sure it's not someone who's got a lot of floaters. And sometimes there aren't floaters, it's just simply the posterior vitreous face that you can see over here that's still attached to the nerve, or is just premacular. The retina is 200 microns thick, so this is just 300 microns in front of the retina. And that's when it can be quite symptomatic. And here again, you see two very, very obvious floaters that are going to bother patients potentially post-operatively. There's someone where you can see there's something happening in the RPE, and on close examination, you can see that there are drusen and there's leakage in the retina. And again, this is a case where you definitely are not going to be using a diffractive multifocal optic, and probably staying away from most multifocal optics. Same thing over here with fluid in the retina and epiretinal membranes that are distorting the retina. Now, this is one which I'm sure we'll have in the discussion, because I'm sure the experience on the panel, we're going to find that if there's an epiretinal membrane that's not really distorting the macular architecture, we know that most of these would not have even been seen without the OCT. They may be okay, but we have to try and bear in mind what we think that membrane is going to do. And same thing over here, they can elevate the retina, and they can actually have some fluid collection under the retina, these membranes. And then just another case of floaters, don't be caught out by them. And here's a case of what looks innocuous, just a vitreous detachment busy occurring, but on closer examination, there might be some level of vitreomacular traction. Obviously, when it's much more obvious, it's easy to make a decision. And we normally wait with a multifocal IOL until that resolves. our retinal colleagues say it's not necessary to wait for a monofocal because they don't think that our surgery is going to impact the progress or the course of the VMT. That's what our retinal colleagues are telling us. And then, this is again, just always have a look at the RP to make sure it's nice and smooth. And then again, an epiretinal membrane. So I try to show subtle cases that you wouldn't necessarily pick up on a quick viewing. And I think anytime you see a scan that looks like this, where there's a very thin nerve fiber layer, although that's not uncommon in a patient with high myopia, but when it's very thin and there's asymmetry and the nerve just doesn't look healthy, it's another place to stay away from a multifocal IOL. So why do we continue to do it? Well, as I said earlier, we want to make patients happy. But to make patients happy with these advanced technology lenses, we need to make sure that we're paying attention to a lot of other issues like you've heard. And once you do pay attention to them, you increase your odds of getting a very good result enormously. So thank you very much.
Thank you, Dr. Cummings, for your wonderful talk. And can we have the translation now?
徐主任，请您也来翻译一下 Professor Cummings 的分享吧。我来共享 PPT。好嘞。徐主任，您那边声音还是有点小。
现在说话可以了吗？声音。
现在好一点。
好的。我这个 PPT 还没有看到。
我已经共享了。Can everyone see my sharing？ 大家可以看到我的共享吗
No, we can't see your share screen. Can you redo that again?
Oh, sorry. Here. No. 现在可以看到吗
Yes, thank you very much.
现在可以了。刚才奥瑟教授也是讲了这个多焦点人工晶体的一个患者选择。那什么样的患者是合适的，什么样的患者是不合适的。好，下一页，谢谢。那对于合适的患者呢，首先这个患者要有明确的摘镜的这个意愿，并且这个患者他是可以理解这个手术是存在着一些这个妥协的。那就是在开场的时候，奥瑟教授就提到了一点，这个对于患者术前的教育，科普是非常关键的，因为我们尤其是在术前要跟患者介绍这个晶体多焦点晶体的特点非常的重要，因为这个晶体它存在着一个要想达到多焦点的这个作用，所以呢它需要有一个分光，那么进到眼睛里这个分光可能会引起一些眼部的异常的不适而且呢它这个晶体如果想要聚焦，它的范围越广，那么它所带来的光感受的异常可能就会越严重。抱歉，上一页我这里边对这一页，我这边把刚才奥瑟教授在开场里边说的内容再说一下，因为那会儿没有翻译到嘛。然后另外呢，对于一些特定的这个晶体呢，它如果想要它的给患者带来异常不适的这个感觉减少的话，那么它可能所覆盖的这个焦点的范围就会越小。而且还有一点呢，就是如果这个患者想要用多焦点晶体达到一个很好的效果，那么在价格上他也要是能够接受，因为它相对的费用会比较高。那么第三点呢，就是这个上一页谢谢。第三点呢，就是患者他是不能够接受单眼视这个混合视力的另外我们在进行手术前一定要进行一个详细的眼部的检查。下一页。那这对于这患者呢，远视患者他会比近视的患者更容易获得一个满意的效果。那么在开场的时候，奥瑟教授也说了一个特定的人群，就是近视的患者。因为近视的患者呢，他有一部分是在术前做手术之前，他的近视力相对的可能会更好。那么他做完手术之后呢，近视力可能会相对的会差一点，所以近视的这个人群在手术前也要对它进行一个非常详细的科普。那么眼部的检查，我们要看这个角膜的 角膜是否规则，眼表是否健康，除白内障以外有没有其他晶体的疾病，有没有眼底疾病，或者是白内障或者是青光眼或者飞蚊症等。下一页。那么针对于角膜的情况呢，我们要关注这个角膜的散光是否是规则散光、不规则散光，以及它的贝令角膜扩张分析，还有它的高阶相差的傅立叶分析，以及我们要关注这个如果用多焦点晶体的话，那么要求它的高阶相差是比较低的。另外还有一个就是它的角膜是否适合增效手术，因为有一部分患者他做完这个晶体植入手术之后，可能需要再进行一个角膜的激光的矫正手术所以术前我们要评估，如果做这个增效手术，这个角膜是否可以满足条件。下一页。那这一个呢，就是一个角膜的角膜散光的图，但是呢，它的散光比较大，所以可能不是很适合一个用这个多焦点的晶体。那么下一页呢？下一页。这个可能是一个做过近视手术的一个患者，但是他从这个图上来分析，他各方面的指标都是比较好的。那么还要看他的这个角膜的扩张分析。下一页。再下一页，就是这两张图呢，它的分析了一下这个LASIK术后这个角膜的情况，那么各项指标也都是相对比较好的，所以如果要进行多焦点的这个手术的话，应该是比较符合的。好，这个呢也是它一个傅立叶分析，它各项指标都是比较好的。下一页。这个呢是可以看一下它是否有这个圆锥角膜以及各个指数的一个分析。下一页。然后我们还要看它的这个汇差是什么样的情况。下一页。下面呢，我们还要关注这个患者的泪膜的情况，它的渗透压是否正常，它的客观散射指数是否正常，以及它的BOT 的一个情况。下一页。后面呢也是看这个角膜的客观散射指数，它的 BOT 都是比较好的一个比较稳定的状态，所以应该相对是比较合适的一个患者。另外呢，我们还要看它晶体的情况同时对这个手术要求是否有能够熟练的进行撕囊，然后没有后囊的这个问题，没有晶体的脱位，悬韧带也是非常健康的。除此之外，我们还要关注它眼底的一个情况，要做 OCT，OCT 有没有异常，有没有黄斑的疾病有没有黄斑前膜、黄斑变性，或者是糖尿病视网膜病变，视神经是否有问题。后面呢几张也是它的一个 OCT 的几个结果，都是一个比较好的，没有什么异常的。如果眼底是这种情况，基本上都是符合做这个多焦点晶体手术的。下一页。好，下一页。下一页。下一页。这个都是这些 OCT 的结果都是比较好的，没有什么问题的。然后呢，这个上一页，抱歉，上一页。放到那个对，这一页这个呢就是刚才 Arthur 教授说的比较有意思的一个情况。我们看右边就是这个 OSI 指数是 1.5 的这个情况。根据 Arthur 教授的经验呢，他说很多患者如果术前做的这个结果 OSI 是 1.5， 他同时没有抱怨他看东西有眩光的这个问题，那么往往他做完手术之后可能也不会有就是抱怨会有眩光等不适。那左边的这个呢，如果他术前是 OSI 是 0.6， 那么很有意思，这就是0.6到 0.9 之间的这一部分患者，他即使他术前没有抱怨说看东西有眩光这个问题的存在，但是他做完手术之后也可能会抱怨有这个眩光的问题。好，下一页。下面的这应该是有3张图，它就是看一个术后，就第一张，它术后呢，患者会觉得有点不适，然后做了这个检查，给他用了一些人工泪液之后，他的这个 BOT 就逐渐稳定了，患者也是逐渐的比较舒适了。下一页。 这个是一个 eye trace 的分析，那么也是一个奥瑟教授比较喜欢的东西，因为它比较直观，可以直接给到患者。如果手术之前做给患者看，就是他看东西视觉不好呢，主要的原因就是他晶体的这个问题但是他同时呢，我们看他角膜的这个移植也不是特别的清楚，所以在手术之前跟他交代的时候呢，也可以跟他说，就是角膜上。就是因为角膜的问题，那么术后也有可能不会达到一个对视力可能也会有一定的影响。下面呢就是说了一下这个存在的一些情况可能会对手术有一些影响。那么下一个问题。这个呢也就是 OCT 是没有什么问题的，都是比较好的。下一页。后面呢一些照片，就是奥瑟教授提供了一些可能就是我们需要注意的 OCT。这个呢看就是 OCT 黄斑这个部分前面有一些浑浊，但是它有可能会是这个就是因为白内障原因导致的。下一页。这个呢，就是它有一些那个玻璃体的后脱离，就是在讲的过程当中，奥瑟教授说，我们在术前关于这个玻璃体的问题，还有它飞蚊症，要跟患者就是要跟他交代清楚，有可能会对术后视力会比较有影响，而且患者他可能就会抱怨有这个飞蚊的感觉。那么他如果是有飞蚊症的情况，我们给他进行飞蚊症的治疗，那么一般都效果会比较好。下一页。这个也是有一个这个玻璃体的后脱离，同时呢看它也会有一些影，这个可能是这个float 就是飞蚊症的影响。下一页。下一页。这个呢就是我们看它有一些蛛丝，那也是这种都是需要跟患者来交代的，有可能会对视力是有影响的。下一页。那这个呢就是有一些这个视网膜的渗液这种呢那就基本对手术是会有影响的，它可能就不是一个很适合多焦晶体的一个患者。下一页。下一这个也是眼底都是有问题的，那么这样的患者要特别的注意这个这一页呢，我们看它有一个玻璃体黄斑牵引，那么有的时候同时呢还有一些 flow 就是玻璃体的浑浊，那么都是要跟患者交代。这个手术呢可能会对玻璃体黄斑牵引，就是玻璃体黄斑牵引它会有一点的影响，那么手术的时候医生也都是要慎重考虑，那么手术的过程当中也是要非常的小心。这个就是一个放大的玻璃体黄斑牵引的一个情况。下一页。下一页。这个呢下一页。这个呢我们看这是能看到是有黄斑前膜的所以术前的这些 OCT 的检查，眼底的检查是非常关键的。那么下一张呢就是这个我们能看到很多的这个 floaters， 就是玻璃体的浑浊，一定要跟患者跟他沟通好这个问题。那么这个是一个高度近视的一个患者眼底的一个表现，所以术前的这些眼底的检查是非常关键的。那么对术后患者的视觉效果也是可能会有影响，那么都要跟患者沟通。那么未来呢还是会继续应用的这些多焦点的晶体达到患者的满意是我们首要的任务。同时呢我们做的越多，临床经验的积累也会越多，那么同时也会有很多这个个人的获益比如说我们为患者提供这个非常好的视力，那么他呢也能够进行摘镜，有这个脱镜同时呢我们还有更加提高的这个安全，能够激发更多人们的潜能。谢谢。
谢谢。我们所听到的刚才上述提到的每一个环节对屈光手术 性白内障的成功都起着非常重要的意义。现在我们可以叫 panelists 来我们讨论。Thank you, everyone. I think each of the steps that we mentioned from all the lectures are very important to the success of refractive surgery. And therefore, I think we all learned a lot from that. I think now I invite all the speakers, including our faculty from China, to join in the panel discussion. Maybe I can start first with posing a question to the speakers. Now, this seems to be very complex for the new beginner to embark on this advanced technology IOL. So there seems to be so many investigations to do. How do we simplify that? Do we have to do 3 or 4 different types of anterior segment imaging and OCT and everything before we start? Or is there something that we can simplify first and only reserve those advanced imaging for suspicious cases? Or do you say that we should routinely do all the imaging? Maybe I'll ask Sheraz Daya first.
Great, thank you. So what I do with my staff is that when a patient comes in, say for any refractive procedure, depending on their age, we will guide them down the patient care pathway, either for refractive lens exchange or cataract or laser vision correction, ICL. And what we do on everybody is the OPD3. That gives us a lot of information about what's going on in the cornea, in one column, the overall eye in another column, and inside the eye in a third column. And then based on that, we decide which direction we're going to go in. If they're going down the refractive lens exchange route, and they're sort of borderline in terms of age, we will do an HD analyzer. But we start with that as a basis and then go on from there. That every patient, if they're having anything done intraocularly, will have an OCT. So all of them will get an OCT. I think that's mandatory, as has been illustrated very well by Arthur. And I think you do need to decide based on what you find clinically as well as to what's appropriate. But for me, the OPD3, for advanced lenses, the OPD3, the biometry, and OCT are absolutely vital, along with the HD analyzer. That gives me a lot of information just right there. Endothelial cell counts and so on can be based on what I see when I examine the patient. But we have algorithms. If anybody has a corneal thickness of more than 600, they automatically get specular microscopy. So there are sort of systems that we can use, and then we ultimately have to use our heads as well.
Thank you. Mia, is there any translation?
王医生
The summary of that.
可以请您简单的做一下总结吗？就您的问题，然后和专家的回答，您可以简单的总结一下吗？哦，没关系。赵远，您能帮忙就是简单的总结一下吗
？Sorry, I didn't. Sorry, I didn't catch all of the ideas the professors just presented.
I think what Dr. Daya said, although all these tests, in my understanding, is that it's probably very helpful, but you have to probably have a certain system to sort out what kind of a patient profile they are, whether they are youngish, they are coming for refractive lens exchange, or they are purely a very cloudy cataract case. No, they have a different approach. But I think what we all agree is that you should have a very thorough examination of the eye. You must do OCT, which is mandatory now. If you want to do any, not just only advanced technology cataract, you should do it for every cataract operation because you have to find whether they have any corneal retinal pathology, which would adversely affect your outcome. And I understand from Dr. Daya also that says that depends on what they find in the anterior segment screening, they will do specific tests. For example, if a patient has got very thickened cornea, perhaps that will call you to do a specular microscopy to see the state of the endothelium, etc. Is that correct?
That's right.
Yeah. So can you just help translate in this simplified answer to the general audience of more than 1,000 out there?
是的，陈校长，您能帮忙简单总结一下吗？
好的，那个前面那个Daya的教授，他主要是说了一下，就是如何采用一些就是术前的那个评估设备，尤其是一些前接的设备来对患者进行一些评估。因为在他眼里以后看，有些患者是可能是就是做我们说的那个 refractive， 就是晶体置换手术。那么患者的晶体并不是那么浑浊，可以根据患者的角膜的相差或者眼内的相差进行评估。当然，患者明显的病症都患关于采前面因为他反正是特别强调了，好像是用那个相差仪来评估了一下到底是眼内的一个相差的情况，还是一个角膜的相差情况，然后根据这个情况来选择患者是做一个屈光的手术，还是做一个晶体置换的手术。不知道赵院长有补充
？To Dr. Francesco, how important is the determination of angle kappa in every cases? Do you do it routinely, or you pick if you want to put diffractive IOL that you want to do the measure the angle kappa, or you have already done it in a routine to measure before you consider a multifocal IOL?
Well, let's say that if you're running some basic exams, for instance, as Sheraz suggested, like the OPD3, you have a measurement of the angle kappa at any time you do it. So it comes very, very routinely. And the question of the real value of kappa angle is still kind of open. I mean, there is not a common agreement on the importance of it. I would say that to stay on the safe side and not to be, frustrated by suboptimal results when you're starting doing this kind of surgeries, I would just advise not to take the difficult cases as the first ones. This is why I'm emphasizing the importance, maybe just not to, to start challenging and, getting your experience on cases with some sort of large kappa angle. On the other hand, I have to tell you that I didn't see any real strict correlation on the misplacement on the kappa angle and systematic complaints by the patients. They're very random. They're not very They're not very consistent. So it's more a precaution that I would have instead of a straight rule that I would give.
Yeah, that's what I thought. That's why I never really put a lot of emphasis on that, because I never thought that it's going to be a big problem, unlike all the other investigation. But actually, now that you highlight that, I probably just sort of look out and then see whether they have any bearings on some of the unhappy patients. Professor Zhao Ping, 你有什么意见吗? Do you have anything to add?
我正想请教一个问题。那就是对于非常高度的远视，如果这个病人呢是可以矫正视力，还是可以矫正到一定程度，然后呢患者有比较强烈的愿望做这种多焦类的人工晶体的话，可能呢我们一般的晶体度数可能不够，那么这个时候呢可能涉及到一个 PG back 这样的一个植入。我想请问几位教授有没有这样的经验？ My question is that for a very high hyperopia patient, if he or she can be the vision can be corrected to a certain like 0.5 something like that, and the patient want to implant multifocal intraocular lens, do you have any experience about the PG back implantation?
Open this to the panel. Yep.
Yeah, I've used piggyback implants. Do you mean piggyback trifocals or piggyback spherical equivalent? So if somebody's do you mean somebody who has a residual refraction that you need to correct? Is that right?
Yes.
So you mean they're about 0.5 diopters out?
No,
Usually,
I mean, before the cataract surgery, the patient, his vision can be corrected to 0.5, 20/40.
yeah. And so you mean they might be slightly amblyopic, is that right?
Yeah.
Okay, and if the other eye is normal and good, I would have no hesitation in putting in trifocal lenses in these patients. As both Arthur and Francesco pointed out, these are some of the happiest patients because they're going from nothing to everything. Although it's not perfect, remember, they're not used to perfection. We want perfection for them, but they're very happy with getting better vision unaided than they have presently. So I have no problem doing that in patients who have a vision of 0.5, best corrected. I'll put in a trifocal lens as long as they're going to have it in the other eye as well.
My question is that for the highest diopter intraocular lens, it is not available.
Right.
For example, for 30 diopters, and if the patient need 34 or 35 diopters intraocular lens, will you implant PG bag for the design for the patient? And
yes,
I'll
put the trifocal in the bag.
How to design it? How to design it? I mean, how to distribute the refractive power for the two intraocular lenses.
Okay, so I try and keep all my variables constant. What I do is I don't go above 10 diopters if I possibly can. So I usually use a 10 diopter spherical piggyback. So I put the trifocal in the bag. So say it's a 38, right? I'll put a 28 in the bag and I'll put a 10 on top. Okay, but so I won't go all to the maximum of 30 or 32, whatever they come in, and then do the balance. I will stick to a 10 diopter piggyback always. And I won't go beyond that because then you have to start working out the calculations and using piggyback formulas. But up to 10 seems to work quite well. And when I check my own data, I know I've got one constant, and that's the 10 diopter add-on. And it seems to work out quite well in my hands.
And where you put the PG bag intraocular lens in the bag or in the sulcus?
I usually put it in the sulcus. So I use a 3-piece. Usually it's a silicone lens. Most of the trifocals that I use are acrylic, now hydrophobic. Those go in the bag, and then I'll put a 3-piece lens in the sulcus.
Okay, thank you.
So I always have the question about the piggyback intraocular lens. So do you have any experience about the add-on trifocal intraocular lens like the random one? It also can put in the sulcus. So yes. It means that you just can put the monofocal intraocular lens in the bag and put the add-on trifocal intraocular lens on the sulcus.
Yes,
which is better.
So Raina has just brought out a publication on this, which will be a supplement on cataract and refractive surgery today, Europe. You'll be able to find it online as well. This is on I've written an article on this very issue that you just discussed. So the duet procedure, where you put a monofocal or a monofocal toric in the bag, and then you use a Sulcoflex trifocal on top. And that's a very good option, but you do need to make sure you've got enough room in the anterior chamber and that the iris is not going to be chafing against the lens. Certainly you cannot do that in patients who have uveitic type problems, because if you've got iris contact with the implant, they will have problems. And anybody who might be a diabetic, I put them in diabetics in the hope that I could take the lens out if they got problems at the back of their eye. I won't do that anymore, because diabetics will get a lot of inflammation in their eye, especially if the iris is touching that lens. So I don't use that in diabetics now. I thought it would be a great option for them, but it's not. It's a good option otherwise. So if you have any doubt that you might have to take the lens out, then you can put a trifocal lens on top of a monofocal lens in the bag. I've done a lot of them, but I have to say I've never taken out any trifocal piggyback lenses yet. Not good.
Thank you for your information.
there's a question from the audience for all the speakers. The question is that what is the target refraction for your multifocal lens? And what are your biometry formula of choice for high myopic, hyperopia, and post-refractive? I think they are several components. So any takers, what is the target refraction? I would thought it's ametropia for myself. Dr. Cummings?
With most of the IOLs, the trifocals, we would aim for the first correction under 0. So emetropia or -1/4 or -0.1, that sort of thing. The formulas we normally use are, the easiest one is Barrett for post-refractive. That tends to work very, very well. We tend to use Haggis and Hoffa-Q, but sort of more Hoffa-Q for some reason for hyperopia for us. And then SRKT normally works quite well for myopia, and we sometimes do the Koch-Wang adjustment for the higher myopes. But generally speaking, those would be the formulas, and normally just under 0.
So I find that hyperopes hate being myopic, and myopes hate being hyperopic. So for the myopes, I'll tend to do just under what you just mentioned, Arthur, if it's 0 or minus, and sometimes actually even go in the non-dominant eye, even with the trifocal, because they really want that near vision. I might even go down to -0.37 or whatever. I see that if it being 0, I'll make it even more myopic in the non-dominant eye. When it comes to hyperopes, I will always go above to plus on the hyperopes because they just hate being myopic. They don't understand it. They're miserable about their distance vision anyway because it's a different quality, and they can't stand being myopic. So that's been my experience, and it works quite well for me as long as I get it on target. The formulas I use, again, I try and keep everything constant. I use the Holiday 2 formula. I've compared it against the Barrett. In our hands, the Holiday 2 is a lot more accurate than the Barrett. We need to, I think it's probably a publication we need to put out there. So I use the Holiday 2 formula invariably in all these patients, and it holds me in good stead.
Dr. Carones, your view?
Well, not to repeat what it has already been said, there are some presbyopic retin IOLs where for any reason you may want to target a slightly higher myopic. And these are those called like extended depth of focus or increased range of vision. And when you are planning to get more spectacle independence with these IOLs, you may want to have the dominant eye targeted plano and the non-dominant eye targeted slightly myopic. All these kind of IOLs increase their performances when approaching like mini monovision or micro monovision approach, and patients get significant more spectacle independence. But this is basically the only generalized indication that I would give only for IOLs that are extending the depth of focus, increasing the range of vision, and not for the trifocals. And formulas Barrett, only Barrett, Barrett 2, Barrett 2, Barrett 2. I mean, True K with the IOL Master 700 works just perfectly, and I like to use the True K for all cases, pre-op, post-ops. I mean, post-refractive surgery, any cases.
Okay, the question is that among the panel, how many of you will be happy to implant multifocal lenses in post-refractive cases, post-refractive surgery cases, laser refractive? Dr. Cummings? Or if you don't implant, what do you suggest?
I do. So many of our cataract patients have had previous refractive surgery, and many of them chose blended vision. So if they've had blended vision before and they've done really well, I just keep on going with that. If someone has for the first time, they were emetropic, and then they accepted the reading glasses, and then eventually had got cataracts and they wanted to, I'd go through exactly what you heard today from Francesco and Sheraz. Look at the corneal optics, look at the high order aberrations, and if those are good, you can go ahead. And we've got devices that can measure those errors, and we have a few limits in our mind of the height of error you can accept. I did a survey for the American Academy a couple of years ago on post-refractive, and it was surprising at how well post-refractive eyes do when they're well selected. They can do very, very well. But Sheraz has a lot of experience in this space.
Yeah, so I do at least two patients a week where I have a lot of patients who've had previous laser eye surgery, they're now coming back 20 years later with cataracts or changing in their refraction because of lens dysfunction or sclerosis. And we have a very, very good outcomes in these patients. And I just follow the same rules that Arthur just mentioned, the rules that we talked about in the seminar, which is make sure the cornea and the tear film is okay, in which case they should be fine. If they've got decentered ablations or bad dry eye, those have to be sorted out first before you can go ahead and do this kind of surgery on them.
Okay.
And
Now,
I would agree.
If you felt, sorry, go ahead.
Just want to say that I would agree with the two of them. I would not consider them as the best candidates to start with, just because of the higher likelihood to have maybe suboptimal results related to biometry. So maybe this kind of patients are to be considered the second step patients and not the first to be chosen.
And if they have a bit of an aberration, which you think that is probably not suitable for multifocal, would you implant a monofocal with a monovision? Okay. I think among the audience out there, my understanding is it's a mixture of audience. There are people who are just embarking on cataract refractive surgery, and so I think our topic today is about patient selection. I think you must know your limits. I think you have to go step by step, baby step first, and don't try to take in all the complex cases. I know we are discussing a lot of very unusual cases, cases that are not ideal. But it's not that they can't be done, but you perhaps don't start with these cases, otherwise you'll be really discouraged with bad outcomes. I think I just want to put that in perspective. Okay, I open any other question, any other suggestion that the panel may want to bring to discuss and highlight, because we still have about 5 minutes of discussion left.
I have a couple, if you don't mind. Sheraz, I wanted to ask you and Francesco, if you had a patient who was +8 in both eyes and they were slightly amblyopic in both eyes, would you still consider a trifocal?
To what level amblyopia?
0.5 to 612, 20/40. Yeah,
I would and I have. Actually, what turns out to be quite interesting is they are not as amblyopic as you think they are. Because what we think is the amblyopia is actually an optical phenomenon. They got optical problems. And often those patients you're talking about have astigmatism. So when you correct the astigmatism and you've got them spherically emmetropic, they think you're a genius. They've had an improvement in their vision and best corrected vision too. I don't know if you find that yourselves, but that's been my experience anyway.
Francesco, do you have a comment?
I would say the same. The only point that I would add is maybe in this case the need to screen for binocular vision. I would do like a contact lens trial as to make sure that the patient is not going to have double vision after surgery, because there may be a likelihood that the surgery can bring to that unlikely event.
I've noticed once or twice that patients, of course, they love the visual freedom, they've got an expanded visual field, they like all those things, but they sometimes complain of the lack of magnification. And so they were amblyopic, but they got massive magnification from their spectacles, and that's sort of compensated. And now they improve, and they know they're better, but they're just saying, I'm not seeing quite as well as I did before. And then, Francesco, you're also targeting hyperopic patients slightly plus, like Sheraz is doing. I mean, I understand it completely. I just haven't actually heard it before.
Yes, I do, and I have the same feeling. I had the same report by the patients as regards the loss of magnification effect. But at least in the patients that I have been following, it's very transitory. I mean, a month later, they will not say anything at all related to the loss of magnifying effect. So it's immediate because the day after they see smaller, but 1 month later they don't remember how they were used to see before.
They've got a neuroadapt, and also they've got what they really like is the increased field. Because they get the jack-in-the-box phenomenon, and they've certainly got a wider span. And they've noticed it when they're driving, for instance, and they can see the rearview mirrors, the side mirrors, and so on. Before it was a constricted field by comparison.
type of patients we see are not so much hyperopic, but more myopic here. So that's also a challenge because sometimes as an extreme myopia, it's very difficult to have very good biometry. Sometimes it's a surprise. And secondly, there's not many established lens company have a range for the extreme myopia. So that's why here we will probably at the rate higher myopia, we just use give them a single monofocus lens with a monovision concept. I think one of the topic that we probably didn't cover here is that how do you take to account of the influence of posterior corneal astigmatism in your biometry? I mean, we're all talking about just putting a lens, but we're talking about choosing the correct patient. But any pearls on this, what you should do? How do you determine astigmatism in your patient, so that we obviously need to get rid of that because there's one big source of happiness, especially in multifocal lens. Since you're on the screen, Dr. Daya.
Personally, I don't take into consideration. I take a glance at it, but I've never seen really high magnitude issues. The ones where I may pay a little bit more attention is when they have against the rule astigmatism. But generally, I don't really bother with the posterior corneal astigmatism. Personally, I think it's overrated. My enhancement rate for patients after lens replacement surgery is less than 1%. So, top up laser or top up lens, or so it's very low. So overall, our patients are happy. I just wonder if we're trying to treat ourselves more than we're trying to treat our patients in looking at all these different things. And that's my own personal view. However, when it comes to keratoconus, and I'm putting in a toric lens in those patients, I will try and adjust their lens to give them the full range of as wide a range of focus as possible by looking at the topography, looking at the posterior astigmatism, because there it's significant. It's highly significant in terms of the toricity from the posterior segment. So you can't just depend purely on the anterior. You need to know what the posterior is. But for normal eyes, I've looked at it, and I've not incorporated that as an extra variable to give me a headache. I seem to be doing quite well doing what I'm doing right now, and I'm just continuing. So I don't think we should make it too complicated. So just one more thing about, I think for the audience out there, especially the new ones, the newbies starting this sort of business, it must be really complicated for them to hear all this smattering of information all at one go. I think we're making it very complicated. You can make it simple. And just to go back to what Francesco said, start with the straightforward cases. And as you get confident and you build up, then look at all the other issues. But you got to figure out what this ideal case is to begin with, and start there. And all these other things that we've talked about, don't let that confuse you or put you off.
Right. Any other pearls to share?
Okay, I think the timing. Thank you so much for all experts. We have very wonderful night. We have active discussion today. So actually, I have a good news to tell everyone, because today we have more than 2,000 clicks, like audience to watch our live discussion and webinar. So it's really wonderful tonight. And at the end, we would like to invite Dr. Zhao Ping to give us a comment and feedback. 赵平院长，能请您给我们做一下今天的总结吗？
好的，谢谢。那么今天呢，我们非常高兴的邀请到了几位教授，就虚光性白内障手术的患者的选择，还有一些特殊的病例呢，和大家进行了分享。那么从教授的这些个病例当中呢，尤其是在讲座当中呢，在讲到病人的病例选择的时候呢，可能有一些在我们国内的医生呢，至少是在我们的日常的临床实践当中呢，可能有一些问题呢，有可能是被忽略掉的。比如说呢，对于角膜的一些情况像一些眼表的情况角膜本身的情况包括尤其是在选择高端人工晶体的时候，其实呢，我们在做这个散光性的人工晶体植入的时候呢，可能考虑的多一些的角膜的情况可能相对考虑多一些。但是对于多焦类的人工晶体的时候呢，可 可能呢在这方面呢，尤其对眼表的情况，可能是关注的不一定非常的多那么像今天呢我们教授分享的像这种cornea gutata像这种情况呢，过去呢其实我们可能是没有去很好的去注意到包括像有一些个像这个角膜内皮相对偏少的病人这样的术后的有一些表现呢，有可能我们并没有非常多的去关注总之呢，今天呢是非常好的这样的一个讲座让我们也是收获非常多，谢谢 ，Thank you。
Just now, Dr. Zhao Ping made a summary about this panel, especially about patient selection. He mentioned in China, actually, our doctors may pay less attention to the corneal conditions against the patients with multifocal lens. So we learn a lot actually today. So thank you again for everyone. We have wonderful tonight. Thank you so much. I think that's all for our panel tonight.
Thank you, everyone.
Thank you.
Thank you. Thank you. Thank you.
Bye bye. Good night.
Bye bye. Thank you.
Good afternoon.